Perfect. I think we're going to get started today. So thank you everybody for being here. We have a packed day, which is why we're getting started right at 1 o'clock. So thank you everybody for being here for the launch of the 2020 Newborn Screening Bootcamp. Thank you again for everybody's patience and flexibility this year as we move from an in-person event to a virtual event. We're really excited about everything that the bootcamp holds for us this year, and we're really excited about specifically today's session. And so today we're going to focus on an introduction to newborn screening and the recommended uniform screening panel and the nomination process. So we're really excited, and we're going to move forward and get right into the content. First, just a quick thank you to our sponsors, which allow us to hold a bootcamp this year. And moving on to our first speaker. So Dr. Puryear will be talking about newborn screening and the recommended uniform panel nomination process. So Dr. Puryear, turn it over to you.
Good afternoon, or if you're in the West Coast, good morning. Can I have the first slide? I'm here representing the NIH-funded Newborn Screening Translational Research Network and the American College of Medical Genetics and Genomics. And so over this next month, while you participate in the boot camp, I want you to remember a mantra, that newborn screening is always more than a test. It's a program that includes a screening test, but also a whole coordinated system of services that are designed to bring the screen-positive infant to diagnosis and life-saving treatments. Can I have the next slide? Today we'll be presenting a short overview of newborn screening, and then for the remainder of my time, I'll focus on the decision-making processes surrounding newborn screening, transitioning to how conditions are added to the recommended uniform screening panel. Later in the month, Dr. Alex Kemper will go into that in a lot more detail. So next slide. In the US, newborn screening begins within 24 to 48 hours of a child's birth. Every year, our 4 million infants are screened universally for serious but treatable disorders. And it's important to remember that this system operates universally regardless of place of birth, race, income. For blood spot screening, a few drops of blood are obtained from the baby, usually through a heel stick. The blood spots are sent to the laboratory that's part of the state public health system. And hearing and congenital heart disease screening occur at the bedside in the nursery. Screening results are reported at that time to attending physicians and also to the state newborn screening program, and of course to the parents. Next slide. Next slide. Newborn screening is considered a vital public health program, much like our immunization programs and our current state public health COVID programs. It was established to identify infants early to prevent or reduce catastrophic consequences to the babies and families affected by the screen disorders. If these disorders are not detected early and treated soon after birth, they may cause either mental retardation, severe illnesses, or premature death, or physical disabilities, or a combination of these. Next slide. In the US, newborn screening systems are state-based, and that's important to know. So they are governed by the laws of the state, and not governed by the federal government. Each state bears the financial cost of screening and decides what conditions the newborns who are born in that state are screened. And these decisions may consider the frequency of the disorder in the state, the availability of treatments in the state for each condition, and can the state afford to screen? Does screening for a disorder require buying equipment or acquiring expertise they do not have? Again, because newborn screening is a system, they have to have all those pieces in place. Next slide. Structurally, newborn screening may be divided into 5 component parts, consisting of screening and diagnostic testing, evaluation, and follow-up and treatment, with education as part of all of these steps in the screening process. Next slide. As the parts of the system need to be coordinated to function properly, for instance, you cannot screen for an infant without being able to deliver a treatment and the ability to pay for that treatment. Coordination occurs between the state, public health department, and clinics within the state and schools. And this is really important with hearing screening. We often see regional and national coordination to share resources. For example, CDC labs provide quality assurance services. Screening includes hospital-based screening, as with hearing, and congenital heart disease screening, or sample collection and sample submission with laboratory-based screening. This is followed by giving the screening results to the family. If the screen is positive, more testing is performed to confirm the diagnosis. This often entails subspecialist assessments, usually with additional testing, and sometimes that's with DNA. The process is both clinician and protocol driven, and if needed, genetic counseling is offered. If the infant is diagnosed with a disease, treatments are prescribed and referrals are made for further evaluation if needed. Next slide. This slide represents the multitude of stakeholders that are important to a newborn screening system. And here you see state public health departments, medical providers, families and consumers, and researchers. Again, all these stakeholders are needed to provide cohesion and coordination for the newborn screening system. Next slide. Now, let's step back in time. In this slide, you'll see that in 2000, most of the states screened for 8 conditions or less. And that's significant. It was time when you were screened for, what you were screened for depended on what state you lived in, or what state actually you were born in, not necessarily the state you lived in. So for instance, an infant who family lived in Virginia, but the child was born in DC, they were screened for what DC was mandating, not what Virginia may be mandating. And when newborn screening programs began, conditions were screened one at a time. You screen for phenylketonuria with one kind of technology, you screen for congenital hypothyroidism with another kind of technology. But in the 1990s, we saw an expansion in screening technologies and the ability to use multiplex technologies came into widespread use. And this was in the late 1990s. We could now screen for many conditions at one time with the introduction of tandem mass spectrometry. And we also saw the introduction of point-of-care screening during the 90s. For example, newborn screening for congenital hearing loss was established in 1993. And now we have screening for congenital heart disease. This expansion of screening panels occurred rapidly over the next 5 years from 2000 to 2005, but still with little uniformity between the states. And then next slide. And now, today, we see the increased uniformity between states and their screening panels, where all states now screen for more than the 30 core conditions that are on the recommended uniform screening panel. Next slide. So how did we achieve that uniformity? Next slide. In the early 2000s, 3 major events set the stage for bringing uniformity across the country. The first was the formation of the Secretary's Advisory Committee on Heritable Disorders in Newborns and Children. It was chartered in 2003. And it was established under the Child Health Act of 2000. Its first meeting was in 2004. The second event occurred in 2005. The federal government requested that the American College of Medical Genetics evaluate newborn screening programs and submit a report on what state should be screening for. This they termed the Recommended Uniform Screening Panel. That was presented to the federal government, and in turn, that report was presented to the Secretary's Advisory Committee. In 2005, they recommended the adoption of this uniform panel and by the Secretary, and the Secretary of Health and Human Services adopted this panel in 2006. And here you have what's termed the Recommended Uniform Screening Panel, or RUSP. Next slide. Who decides about newborn screening in the US and how? So again, remember, ultimately what conditions are on the state newborn screening panel is a state decision. And in states, the decision may be made by state legislatures. Every state has a law mandating screening, sometimes specifying the disorders, and even the testing laboratories. Or the state health officers or state boards of health may also delegate that decision-making authority, often to the state advisory committees. All but 2 states have standing advisory committees, and they are also given the authority to put forth recommendations. And at the federal level, we have, of course, the Advisory Committee on Heritable Disorders. They make recommendations, but cannot dictate state policies. Next slide. The federal committee considers the evidence for screening in these categories, looking at the conditions, screening tests, the ethical and legal issues, public health impact of the recommendation, and also the scientific literature. Next slide. They examine the evidence for screening by looking at the usual care and course of the disorder. What's the case definition? Is the protocol established for the care of the person affected by the disorder? How do you make a diagnosis? What are the benefits and harms of screening and diagnosis? And then they also look at what are the benefits and harms of the treatments. Do we have intermediate outcome measures to evaluate the screening process, to evaluate the medical condition of the infant identified, and to evaluate secondary outcomes that are as they are related either to the patient or even to the family? And what are the healthcare system's needs if and when you establish screening for a specific disorder? Next slide. And here you see just an outline of the process of nominating a package, a condition to the advisory committee, and then the outcome. And in red, except it looks like it's orange, you can see the points of decision making, whether it's evidence to move the condition, the package nomination package to the evidence review committee if the evidence is not sufficient, or if the condition, it's reviewed and the condition is not ready for inclusion into the recommended uniform screening panel. And those recommendations are given to the secretary, and that secretary either accepts the recommendations or declines to accept. Next slide. So you've made a recommendation, or you're going to make a recommendation to the screening panel. And I just want to put it in perspective of how long this process can take. Here we have how long the process for both recommending and evaluating severe combined immunodeficiency disorder. From 2001, where a conference was held at CDC, which examined whether or not we should be doing newborn screening program, to the assay discovery in 2005, the development of quality assurance materials by CDC. That took a 3-year period. There were some state pilots. And then finally, a recommendation to the Secretary's Advisory Committee. It took, as you can see, from 2001 to 2013 to have full implementation of that, both the recommendation and the implementation of newborn screening. So it's a long process. And currently, from the time of an advisory committee recommendation to full implementation takes about 4.3 years. And then using sickle cell disease as a comparison, I want to point out it took 20 years for newborn screening for sickle cell disease to be universally offered in every state in the United States. A recommendation was made in 1986 by NIH and money was brought forward to implement that recommendation, but took another 20 years, 2006, before it was fully implemented. So it's a long process. Next slide. I want to thank you for, pictures along the bottom. I want to thank everybody for being here today. And here's my contact information plus my email and our funding source from NICHD, NIH. And please feel free to email me with any questions. Thank you.
Thank you, Dr. Puryear, for that wonderful presentation. There are a couple questions, and I want to stress Dr. Puryear's comment. If you have any additional follow-up questions, please do feel free to contact her at the email listed. But I do want to ask one of the questions that did come through. And there was a question that says, I wanted to confirm what Dr. Puryear said about newborn screening. There has to be a treatment, and you have to be able to pay for the treatment. Does that mean not every baby gets the same newborn screening within a state?
I'm not quite sure I understand, but newborn screening, the panel that's decided upon within the state is offered universally. And with, I guess I'll use with sickle cell again for an example. The big breakthrough in universal treatment came about through the implementation of the Affordable Care Act, or Obamacare. But generally, insurance pays, and if the infant doesn't have insurance, then the state picks up the cost for both the screening and the treatment.
Perfect. Thank you so much. And again,
if I understood the question, but
that was great. Thank you again. I do want to stress, if you have any additional questions for Dr. Puryear, her email is right there on the final slide. In addition, we'll try to answer the Q&As in the Q&A box as they come in. I want to stress, if you do have any questions throughout the presentations, please do put them in the Q&A box as opposed to the chat box. That is an easier way for us to answer your questions as they come in. So thank you again, Dr. Puryear. And we're going to move on to our second presentation. I can move the slides to Ms. Terry Klein, who is the President and CEO of the National MPS Society, who's going to discuss kind of the patient organization guide to putting your package together. Terry, if you're ready to go.
I am. Thank you so much. Hello, everyone. I'm Terry Klein at the National MPS Society, as Dylan had shared, and thank you, Dr. Puryear, for providing us information that really is a nice segue into what I'm going to provide for all of us, which is putting a patient organization guide together and sharing with you how we put forth the MPS2 RUSP nomination. My background is that my daughter is a patient with mucolipidosis type 3. So not only do I work for the society, but I also am a parent of a patient scientist that suffers from one of these lysosomal diseases. Next. I wanted to share quickly, because I thought it was important, just very quickly, to give you a glimpse in terms of who we are as an organization, as a patient advocacy group, because understanding us will help you understand where you are in this space and how we put this nomination together. So I'm going to walk you through an in-depth project timeline and how we constructed the RUSP packet. We're a nonprofit, we're a 45-year organization, and our mission is to cure, support, and advocate for MPS and ML. Next. So we provide support to 11 of the lysosomal storage diseases, and there's approximately 50. And so our organization is an umbrella organization over mucopolysaccharidosis and the mucolipidosis. Next. As I mentioned before, we are a 45-year organization, and some key information to share with you is that we have 2,100 active member households in our country. We do have a Pathways program which works with families at the time of diagnosis, and so they do have face-to-face meetings, and so our newly diagnosed patients are receiving some really incredible support and care from the National MPS Society. And I also wanted to just put in there as a bullet point that we have over 20 years of legislative advocacy efforts on Capitol Hill, and though I won't be talking about that today, it becomes part of a very critical part of our overall newborn screening program. So this is a presentation about the RUSP packet and how we put it together. But please know that from our organization standpoint, we include it in our overall newborn screening program. Next. So let's talk about creating the RUSP packet. So I really want to provide to you a glance of the organization so that you can identify for your organization how to be best prepared to nominate a condition and to understand what the recommended uniform screening panel is and what it's going to take in order to put a nomination forward. And what it's going to take is science, pilot studies, a lot of expert reviews and information curated together over a period of time and following directions from HRSA and the ACHDNC to put together a proper packet. And I'm going to unpack a lot of what I just said, but I first want to share one thing. When you're putting together a nomination packet, I tried to look at this process first and foremost in terms of identifying our key stakeholders, but knowing that we are moving multiple directives. There's multiple directives for a newborn screening RUSP nomination, and it really is project management and strategic management at the highest levels. So the goal here we know is to screen for MPS II. And then managing each of the components and identifying who are key stakeholders and ensuring that our efforts were and are running in tandem is crucial and timely. Next. So learning and understanding knowledge and architecture. Back in 2012 and today, we had to acknowledge that there's a learning curve for the architecture of the RUSP nomination packet. To begin to build the project out and build the timelines, you have to incorporate learning into your organization. You need to understand what the deliverables are going to be. And if you're not familiar with the language or if any of these words don't look familiar to you on the screen, recognize that you need to get to know them. And it's important to build out the time for your organization to truly understand which each component of the nomination is about, what it means, and then identify who can help you submit those portions. So the first step is going to be to not skip this step. Knowledge is everything. So please don't skip the learning process. The ACHDNC, the HRSA site, they do a fabulous job of providing you the details of what's required for their nomination, how to download their nomination form, and what's required. So make sure you don't skip that. Next. So this is our key stakeholder screen. And this is a screen where we recognize that we each within our patient communities have key stakeholders that are involved in newborn screening. You have to identify who your key stakeholders are when you're going forth to put a nomination together. I'm going to talk about project timelines a lot. I'm going to talk about it a lot in 15 minutes, but it's crucial. If you don't identify who the key stakeholders are at the very beginning, something's likely to get missed. We know the child is the key ultimate stakeholder because they are the ones that will receive the therapy and benefit from the newborn screening. We recognize that. So the child is infused and threaded throughout portions of the nomination process. And we see that in the science and the pilot studies and the information that we're bringing forward in terms of therapies and cures and even harms and use. We're thinking about the child all the way through this nomination process. We also have to recognize who the other key stakeholders are. The clinicians and the researchers, they're going to be part of the expert team that we're going to identify to help you construct this nomination. We have to recognize that the Advisory Committee on Heritable Disorders in Newborns and Children, as well as HRSA, are there to answer questions for you. They're there to support us. So if you have questions in the nomination process, don't be afraid to reach out. There's clarity to be found so that you're not going down a rabbit hole. We also recognize here that on the peripheral, the state health departments, as well as the parents themselves, as well as in time and over time in tandem, patient advocacy groups, as well as the payers, as well as legislators are really going to be key components. If not at the point of the RUSP nomination, it's important to start building them, these relationships during the RUSP nomination, because there will be collaborative time with each of these key stakeholders in the future. And this is your time to start note-taking how you'll be able to use those relationships and be able to have the most collaborative and effective efforts in the future when you're pushing the program forward. Next. So here's the architect of our RUSP newborn screening timeline for MPS 2. We have to recognize, and you're going to hear, as Dr. Purier had stated, later on, you're going to hear a lot of information from some experts that are beyond me as a patient advocacy group about what does it mean to have a pilot study and what does it mean to be able to put together reviews and public commentary. But we have to understand as the patient advocacy group that's putting the nomination forward, what each of these means at the beginning, because anything that we can do to build out these sections in the future are going to be very important. So before we have a nomination, do we have the pilot study? Where is the pilot study? What is the data that's been driven from the pilot study? What are the statistics? Who's helping you analyze that information? Who is the expert team that's bringing this together? And so we're talking about building that expert team. And I'm going to talk about that on the next slide, because as the committee had said, they are expecting us to put together an expert cross-sectional multi-symptomatic expert team. And they're going to be co-sponsors in the nomination itself. And I'm going to show you where that is. It's also important along the way to determine how to develop a library for support for these publications. You want to ensure that not only do you have the information available online, you want to have it easily accessible between all of the members. And then finally, we're going to talk about the reviews and the public commentary and just what does it mean to leverage our partnerships along the way, and always remembering that even though you're in the depths of working through the RUSP nomination, there is nothing, absolutely nothing more powerful than our patient and family stories. So even if you are looking for more information, and even if you needed to have more inspiration, please recognize that this is where you can bring the families into the process for later on when you're talking about public testimony and you're talking about the awareness component. Next. So understand the value of the newborn screening program. Examine the laboratory testing methods, the follow-up protocols, and the communication pathways with families and the health providers. The Newborn Screening Saves Lives Reauthorization Act that was started in 2014 was before then, but that act in specifically really encouraged pilot studies to be conducted on these new conditions that the ACHD&C might add to RUSP to ensure the screening is ready for nationwide implementation. So there's a value behind the pilot studies. So before you're thinking about the nomination process, you really need to understand what a pilot study means to your patient community and that specific disease, and what is the information that needs to come forward and be extrapolated after these pilot studies are completed. An example in North Carolina with the RTI is that we worked as a collaborative consortium, as I've listed there in the bullet point, to be able to drive forward the MPS 1 pilot study, because we put forth a nomination for MPS 1 before we've been doing MPS 2. In Washington, a pilot study was also conducted, and we included that information in our nomination, as well as incident rates of children in screening in both the state of Illinois and the state of Missouri. Next. So this is just a glance in terms of the slide in terms of building out your expert team. I just wanted to have you have a glance of what that looks like for us at the National MPS Society for the MPS 2 RUSP nomination. Many of our co-sponsoring organizations and our affiliates are exactly who might have been on our MPS 1 nomination. We're fortunate enough to be in the space that we have many physicians and researchers who've had long-term careers in these lysosomal diseases. And so this is what it looks like. This is key. Identifying your expert team that you know is going to work with you for, as we heard from Dr. Purier, could be a very long time. You need to be able to know that they have the bandwidth, they have the ability to help you identify key sections, and they have the ability to be able to answer phone calls in a very responsive way. There has to be a level of accountability with the expert team. Next. I wanted to give you a glimpse at some of the conditions and the testing rationale and the treatments, because these are the areas where you're going to be assigning sections of the RUSP nomination to these key experts. And each section should be fully understood, as well as following the directions provided by HRSA to complete the nomination. This is the reporting of the key research and discovery, as well as the statistical interpretation and supporting references for each statement that's required. Plan to build out multiple meetings with your expert team. Plan to write, rewrite, and write again, because this is what it's all about. It's a collaborative process We are in this process even at this very moment as we're working through a review. Basically vet every single word, every sentence, every punctuation mark. Truly, writing matters, and you need to be proficient in delivering factual, articulate, and supported documentation to the ACHD&C. Recognize early on if you need to pivot from someone that's not able to provide you this information. Next slide. This is giving you an understanding or a glance really quickly in terms of the fact that I talked about building your library. Build that library, have it accessible by all of your expert teams, land on a software program that can be utilized online, that can be shared, but remember to download everything to your own files for safety purposes. Next. So let's talk about the project management relationships as I start to kind of wind up the construct, because this is really project management, and I've said that at the highest level. You need to be able to understand who your key stakeholders are, and you need to be able to build your expert team, and you need good writers, and you need people who understand the research and the data and everything that has to do with the components of the nomination process that I mentioned a couple of screens back. Prepare directive timelines. This is what the foundation should do. This is what we should do as a nominator. Prepare your directive timelines. Assign your key stakeholder roles, understand all the testing mechanisms and outcomes and the variability scales, identify any obstacles and barriers, and don't be afraid of them, just identify them so you can work through them. Provide enough research and development for supplemental information and communication. Incorporate team accountability strategies. We know how much our expert team wants to help us, but they need to know what their expectations are from us. So define those at the beginning so that there's accountability and can be successful. Solicit input from other foundations. Recognize we're a foundation that you're willing to reach out to. We're here to help you. And work on both a national and a state level, as Dr. Pure stated. These are recommended on the federal level, but only at the state level will they be implemented. Prepare public commentary for the future. Response teams for nomination reviews, and be present for the public hearings. Recognize that ill preparation can absolutely set you back by months, if not years. You don't want that to happen for the children. The MPS 2 RUSP nomination took approximately 1 year for construction. Next. And then finally, I just wanted to share with you one more quick slide. And this is from my standpoint personally. Please take away the fear. One step at a time will help remove the fear. Recognize that HRSA and the ACHD&C are there to support you and answer any questions that you have. Understand the RUSP nomination process, learn the mechanics, educate yourself, your team, and follow directions. Know how to project manage. Find the person in your organization that can project manage. If it's not you, it needs to be someone else. Utilize the most current tools when it comes to constructing. Jump past a couple. Submit a clean package and provide exactly what the ACHD&C asked for. Follow directions, follow directions, follow directions. Leverage your collaborations with industry, physicians, researchers, hospitals, your patients, and other organizations to prepare for hearings and for follow-up information. Be accessible. Answer the phone. Answer your emails. That's when the building the bridge of trust will take place. You need to be accessible to all of your expert team and be responsive. The RUSP approval for screening provides a guide to states to screen for treatable disorders or conditions if approved by RUSP. But each state is responsible for the legislation state health lab, as Dr. Pure stated, and the infrastructure to find the support for this effort. Know what happens after your submission. Look down the road. And the final slide, please, Dylan. I just wanted to share with you that this is little Lauren on the left. Little Lauren was the reason why the National MPS Society exists today. She had mucolipidosis, but two parents came together at Johns Hopkins Hospital, an MPS 1 young lady and a little girl named Lauren with mucolipidosis type 3. Both of those patients didn't have a benefit for newborn screening. Mucolipidosis still doesn't. We don't have a therapy yet. But look at the two on the right. This is what happens when we have newborn screening. When we have newborn screening, these babies were identified so quickly and right into therapies that their trajectory in life is going to be vastly different than it was decades ago. That's what we keep in mind. This was about the MPS 2 RUSP nomination and putting a packet together. There's no way for me to wave a magic wand. It's a lot of work, but through good project management, good science, good pilot studies ran, and picking the expert team, you're going to be able to do this. Thank you.
Terry, thank you so much for such a wonderful presentation. Before we get to our quick 5-minute break, there is one question in the Q&A that I want to make sure that I asked. And so the question is, what is the interplay and coordination between patient advocacy organizations and newborn screening test developers in putting together the RUSP packet? Who can submit the packet?
Well, we will be the ones that submit the packet. So it's our foundation that will be the nominator that actually submits the packet. And what we're doing now is we work with patients and patient advocacy groups, first of all, at the beginning to understand what might have been their hurdles or their obstacles. There's lessons to be learned by talking to the other patient advocacy groups that submitted a nomination. And so take those phone calls in advance so you can kind of understand that. In the end, we are the responsible party for submitting the nomination and ensuring that we're responsive back to HRSA or the ACHDNC committee when they have questions for us.
Thank you so much, again, Terry, for a wonderful, wonderful presentation. And that takes us to our quick break. So we are running a little behind, but I still want to give everybody kind of a chance to take a break, stretch their legs. So we will reconvene at 1:40 for the start of our panel. So again, thank you so much to Dr. Puryear, as well as Ms. Klein for their presentations this morning. And thank you to everybody who's in attendance. And we're really excited to get to our panel. We'll see you in about 4 minutes. Thank you so much. If I could ask the panelists for the coalition panel to start unmuting and starting their videos so we can get started right at 1:40, that would be great.
Hi, everybody.
Hello. Good morning or afternoon, whatever it is.
Good day.
Where am I? Dawn, is your wife doing okay?
She is. Thank you very much. Yeah, we
Great.
had a rough spring, but she's turned the corner.
Wonderful.
So we are at 1:40. In the interest of everybody's time, we're going to get started. So we are very excited for today's panel. We're discussing the importance of coalition building. So and so here are our panelists. I'm actually going to transition to Natasha Bonhomme, who is our moderator today and also our partner in this event. So I cannot thank her enough and Baby's First Test for everything they've done in setting up this boot camp. I'm actually going to stop sharing my screen at this point because this is so we can see the panelists a little easier. And I will turn it over to Natasha.
Great, thank you so much, and welcome everyone. As you were just saying, good morning, good afternoon, good day. We are so excited to have so many people joining us for this session on coalition building. As Dylan said, I'm Natasha Bonhomme with Baby's First Test, and I'm really excited just to dive in. So you may be wondering, you know, for the first panel after our great stage setting from our two past speakers, Dr. Perrier and Ms. Terry Klein, why are we going right into coalition building? Well, just like any other complex system, newborn screening not only thrives, but really survives based off of collaboration and having multiple perspectives and stakeholders come together and work towards making newborn screening, whether it's happen for certain conditions and patient groups, all the way to improving and building upon itself. As a bit of prep for this panel, I thought, well, what would happen if I actually just looked up coalition? What does it mean? And the definition I came across that I really, really liked is an alliance of combined action. And I think that is extremely true, though we often think of coalitions from a policy or political standpoint, trying to get a piece of legislation through. Coalitions come together for a range of different reasons for that combined action. And I think we have really almost basically the perfect panel to talk about this and all the different types of coalitions that can come together and have come together for newborn screening. So with that, I will have our esteemed panelists introduce themselves. They can say their name, organization, and give a few minutes on kind of what they've worked on in newborn screening and what coalitions have meant for them in that sense. So I will just go around the blocks on my screen, and I will start with Don Bailey.
Well, good afternoon or whatever to everybody. Thanks a lot for hosting this panel and for the great introductory talks today. They were super. My name is Don Bailey. I'm a distinguished fellow at RTI International. We're a nonprofit research institute located in North Carolina. Very large institute, but I'm on a team that is now focuses on newborn screening, ethics, disability studies, and really everything around understanding how you can identify children with health problems early and what it takes to help make that happen. I was a member of the Secretary's Advisory Committee for 6 years, so got to see the RUSP nomination process from the inside and to hear so many perspectives from advocacy groups and others who came to present very compelling stories to the advisory committee, but the committee had to make very difficult decisions about which conditions ought to be on the RUSP to rise to the level of a public health non-voluntary newborn screening program. And so it was a great opportunity to see that process play out. And I appreciate Michelle's overview of that process and Terry's great guidance on how to navigate it. Our core program at RTI is called, from my team, is called Early Check. This is a voluntary newborn screening research project where we're offering screening to every birthing parents in North Carolina for disorders that are not a part of regular newborn screening, so that we can do the pilot study work and test other things in order to help advance the cause when it's time and when it's appropriate. So I think we'll be answering questions later, but that's me.
Great, thank you so much for that. Next, we can have Annie Kennedy.
Hi, I'm Annie Kennedy. I'm the Chief of Policy and Advocacy for the Every Life Foundation. And I thank everyone for being a part of this with us. I am very honored to be on this panel with some of the foremost leaders in their respective disease spaces, but also in newborn screening. I was listening to Michelle Perrier present and Terry Klein present, and was really reflecting on where I was a decade ago as I first started to embark on newborn screening, specifically on Duchenne, for some context for why I'm even on this panel. And it was really mind-blowing when you would sit and listen to somebody who had really advanced more and advanced a program in the space talk about all they had done. And it was a lot like sipping out of a fire hose. It could really be overwhelming when you thought about all you needed to do and the infrastructure you needed to build and what you needed to accomplish in order to develop the evidence to get to a RUSP nomination and to even have what you needed to think about submitting a package, let alone state implementation on the back end. And I guess what I would say with respect to this panel is what was the lifeline for us and for the work that I've had the privilege to do in the Duchenne space, but then also in many of the other coalitions I've had the privilege to work, is that what saved us and what sustains us to this day are the coalitions that we get to work with. And if you look at the conditions that have been moved forward, those have been led by advocacy groups who have the power to convene and bring partners together around a shared purpose and a shared drive to really improve the outcomes of newborns and babies and children in that disease space and in that realm. And so I'm privileged to be on this panel and to dig into that a little bit deeper. The work that I'll be reflecting on a lot today will be the work I've done in Duchenne, but just an overall comment for those who are on with us today thinking, oh my gosh, what do we do? Is to say, it's all doable. You just take a breath. All the resources that we're pouring into you will be archived. All the experts who are coming to you over the next couple of weeks are available. And we're delighted to have these experts who are here today to talk about how coalitions are going to be what sustain us as partners as we work together to build this infrastructure.
Great, thank you so much, Annie. Next, we will go to Carolyn Jones. Did you hear me, Carolyn?
I think she can't unmute herself. Dylan, are you able to unmute her? See if we can get that fixed.
Can you hear me now?
Perfect, yes.
Hello, sorry about that. You can't control the calls that come in the middle of the day. But I'm Carolyn Jones, and I'm with Biogen. Biogen was a company that developed the first treatment for spinal muscular atrophy. And it was my role in the company to work with a team within Biogen to support efforts to get SMA on the newborn screening panel. And it was a wonderful opportunity to work with wonderful organizations across the country. I have to tell you, my background is medical technology. I started out the world as a medical technologist, but long since left that realm. But it was a joy to get back into that area and be able to work with newborn screening organizations and the labs. And it gave me an opportunity to learn more about the processes in those labs. And I was able to take that back to the company to support the effort along with Cure SMA to move newborn screening forward for SMA. It is a wonderful community to work with. The newborn screening labs have issues that I think as you develop your coalitions, you need to recognize the areas of support that the labs need as they move forward to add new conditions. And it was my role within the company to try and get a company that was focused on a drug, no knowledge of the newborn screening programs, to educate first internally so that we could help externally. So in the 5 years actually before the drug was approved, my role was trying to educate our folks internally so that we could support the community. So it was a wonderful exercise and experience, and a successful end with the help of many organizations.
Great, thank you so much for that. And I really appreciate speaking about educating internally. Sometimes our coalitions have to start within the organizations that we are living in and then go outward. And next we have Mary Schroth.
Hi, I'm Mary Schroth. I'm the Chief Medical Officer at QRSMA. I've been in this role for 2.5 years. And prior to that, I was a pediatric pulmonologist at the University of Wisconsin, caring for patients with spinal muscular atrophy. In my role and involvement with having SMA added to the RUSP, started off as being part of a coalition and working on the documents that were submitted to the RUSP, and then now transitioning to where I'm leading the implementation process. And I just wanted to comment that the first nomination attempt for spinal muscular atrophy occurred in 2008. And then after Biogen had their product approved for treatment of spinal muscular atrophy, that was a total game changer for newborn screening implementation or approval for newborn screening for SMA. And Jill Jarecki led the coalition of our organization, other patient advocacy organizations in the SMA space, as well as researchers and clinicians and other stakeholders to put together all the documents. And as Annie said, you have to go step by step. The information's there. There's people who have preceded and been successful. It's patience and biting off those small bits to move it forward together. No one person can get through the RUSP nomination process by themselves. So it's been a really wonderful journey. And now we've transitioned from that submission back in February of 2017, which took, Carolyn knows the history better than I do, and Annie, how many years it took to get that actually ready for the submission in February of 2017, but then it was added to the RUSP in July of 2018. And then we've subsequently worked very closely with our partners, our stakeholders, our coalition to implement it across the U.S. state by state, it's been an adventure, and really we've established great relationships. We actually reach out to each of the state labs to both educate, provide support and education, and determine how we can best help them, whether it's information about different testing that other labs are doing, helping to connect them to resources so that they can move forward as efficiently as they can. So thank you so much for inviting me to be a part of this panel. I'm looking forward to our conversation.
Great, thank you. Thank you everyone for those introductions. So I will ask each panelist one question, and then we will get into more of our general panel questions, followed by questions from the audience. So as has been noted before, if you have a question, please submit those through the Q&A and we will get to those. So first, my first question is for Dawn. As someone who has both sat on the committee and heard and read nomination packets, as well as worked with organizations and coalitions that are hoping to submit those nomination packets, from your perspective, why is it so important to use a coalition when pursuing a RUSP nomination?
Well, it's a complicated question, but I think there's some really clear answers to it. So first, it might be useful just to step back for a minute and think about the stories that Michelle and Terry and Mary have all shared about their favorite disorders, and ask, why does it take so long? Why we have to take 10, 12, 15 years from an initial thought about newborn screening, or maybe even an initial nomination, to an actual approval. And they're a sort of complicated set of issues, but it really boils down to two things. One is there are so many individual pieces that need to be worked out before before the screening can be recommended. You've got to have a lab test, and that lab test has to work really well, and it has to identify every baby that has that disorder. It has to be cheap, has to be scalable to high throughput, and it can't have so many false positives that you are identifying way too many children that really have no problems at all. That's just one example of one of the many pieces that need to be in place. The second reason I think it takes so long is that all the policy deciders take on a pretty heavy responsibility, and it is, at what point can you justify going from regular clinical practice to essentially mandating every baby be screened for a particular disorder, and overriding often the consent process, overriding maybe ordinary medical practices of waiting for symptoms to appear. That's a heavy responsibility, because then the public health system is not set up to screen everybody for everything that might have a problem. You've got to have great confidence if it's going to be something that's a part of newborn screening. And so getting all the evidence for all the pieces and then making that case is so critical. So coalitions, I mean, the multiple stakeholders are going to be involved with that, right? So Terry and Michelle gave great examples of all the different groups, ranging from parents to advocates to physicians to professional organizations. There's state and federal advisory groups and programs. There's industry. And all those individuals and groups and organizations have something to offer to the nomination process and to the information that needs to be provided. But no one group has the answer to all those questions, and so you have to have all the players in the room that can answer each of those important questions that the committee is going to be asking. And even if you had all those people that knew all those answers, they can't be successful if they're operating independently. They have to be operating in sync, because they have to be cross-informing each other in ways that are synergistic and help move things forward. What you want to be doing is to try to take that 10, 12, 15-year timeline. Say, okay, what could we do to shrink it? And you're not going to be able to shrink it if you don't have a really well-organized coalition of key people who really know what they're doing, who are systematic and get it, that the pieces that need to be gathered that the committee is asking for are all really important. I think Terry did a great job of laying some of those out. That's an initial response to your question, Natasha, but I think to me it's pretty obvious just from the first two presentations how important coalitions are to ultimately successful RUSP nomination, and none of them in the past were ever successful just because one person stood up and said, I've got a screening test and now you should do it. Or someone else stood up and said, I've got a treatment and now we should do it. Or one parent stood up and said, my child needs to be screened, so come on, do it. It doesn't work that way. You have to have all those people operating in sync to help make it happen.
Great, thank you. Thank you so much for that, Don. The next question is for Annie. If you could talk about the types of partners that you seeked out to complement the patient advocacy organizations when you're building coalitions. I think so often coalitions come together from people who are passionate and connecting with each other, and that could be almost a sub-definition of patient advocacy groups, but then you want to build upon that. And if you could just speak to your experience of how you went about that, what you were, the considerations you made for that.
I think the coalition I'm going to really focus on, and there have been many that I've been fortunate to be a part of, but I think the one I'm going to focus on that would be most valuable here is with respect to the effort to move Duchenne muscular dystrophy forward to the RUSP and beyond for state implementation. That's an effort that I've had the privilege to be a part of for the better part of a decade. And that work really started as an effort to build a national infrastructure for Duchenne newborn screening and was led by Parent Project Muscular Dystrophy, or PPMD. And I was at PPMD at the time. And I really liked how Terry, when in her presentation, talked about there was a legislative component to their work. And while she didn't focus on that for her talk, I think that that's an important thing to underscore, that many advocacy organizations have a broad strategy around their newborn screening efforts, and that there are a lot of resources that are brought to bear on newborn screening programs. And so for the work that we were doing in Duchenne, that these are very expensive programs to lead and run, and that as you're looking at coalition partners, you need a lot of people at the table with you. And one of the approaches that we took is that, first of all, we brought on an expert consultant to work with us to help us map out a strategy, because Annie Kennedy certainly was not an expert in newborn screening and didn't necessarily know how to navigate this whole new ecosystem. So we needed someone who could really help us map out a strategy for that. But then we also wanted to ensure that the federal partners who needed to be at the table investing in a newborn screening efforts, newborn screening infrastructure for Duchenne would have the resources to do so. And for that, there were legislative and appropriations requirements to do that. So we had a really broad long-term strategy around that continues to this day. So there are different layers to that I think are worth mentioning, and that certainly there are a lot of organizations that have done that are available to talk to those who are interested. And then we pulled in partners, we identified and Michelle Purrier mapped out some of the questions that have to be answered, and we really formed working groups around those questions and looked at who were the experts who could help inform the answers to those questions. So we had experts in developing educational supports and resources for families who would need to be supported once newborns were identified. We had experts who could help inform clinical care guidelines for newborns and early identified infants in Duchenne. We had experts who could help with the laboratory aspects of the refinement of the assays, who could really work with us on those components. There were ethical and legal and social implications that we had to consider. So we had ethics experts who were working with us. So we had a lot of different people who were getting pulled in, and some were experts in Duchenne, but many were experts in newborn screening that we were pulling together. And so it became a very broad effort, and just a lot of really willing, wonderful partners who were leaning in to help move this forward. And at the end of the day, you had a lot of publications and a lot of infrastructure that then needed to be tested. And you need to do a demonstration of all of this to make sure that it works, which is what leads to, we keep talking about pilots, but that's ultimately what a pilot is to ensure that everything that you've built will actually work. And so we needed to develop a protocol for a pilot, and that was a whole nother layer of partners that you needed to talk about and needed to figure out how to work with. And there was funding required for that. And so for that, we developed an infrastructure for a pre-competitive consortia of industry partners who would be interested in providing funding to us to work with PPMD to fund that pilot. And so again, there was a new layer added on to the efforts that we were leading. So I'll sort of wrap up there, but there were just so many layers that we were grateful to have the time of the experts, the generosity of the experts who were leaning in. I think one of the things in rare disease that's really important for us to consider is that there are economies of scale, that some of the resources that are being created can benefit other communities. So a great example is in the pilot that we developed in Duchenne. Our timelines for our pilot, to get that pilot up and running, were much shorter because we benefited from the infrastructure of the SMA pilot. So we had the benefit of having worked with some of the folks leading the SMA pilot and having followed what they had done, so that we were able to move on top of the infrastructure as they finished their pilot. That not only shortened our timelines, so we've talked a little bit about how to shorten timelines, shortened our timeline and getting it up, but reduced our cost in getting it started. And so where are the economies of scale and opportunities for rare disease groups to partner together and to work with public health stakeholders and providers to be able to do that more often?
Great, thank you. And appreciate you talking about kind of the benefit of having an infrastructure in place, and that coming from other patient advocacy groups, others who had done this work, because I think that is really where both the momentum and the wisdom can come from. Of course, it's critical to partner with our federal partners, and a lot of kind of the nitty-gritty day-to-day work on pulling these nominations together and all the data and information that goes into it come from fellow patient advocacy groups and partners working on it. So that shared infrastructure is really, really key. The next question is for Carolyn. Can you speak to how you believe industry can work best with newborn screening stakeholders? And you can talk specifically about moving a RUSP nomination forward, and or anything that goes along with that, since I know we spend a lot of time talking about RUSP, but there's a lot before and a whole lot after as well.
One of the things that industry has to start with is understanding who your stakeholders are. As I said, Biogen is a drug developer, manufacturer. Newborn screening is not in our bailiwick. We didn't have a clear understanding of, I did, but people in the company says, well, there's a screening test. Why can't they screen for it? Again, getting back to you have to explain and determine who your stakeholders are. So in order to be helpful, you have to listen. You have to listen first. One of the efforts that I engaged with was to speak with industry partners who had already gone through trying to get a condition on the panel. What were the pitfalls that they hit? I read transcripts from, I guess, the 3 or 4 preceding submissions, so I could figure out who the stakeholders were, and so we would know who to engage. I also looked and dealt with federal partners at CDC particularly to find out who are the movers and shakers in the newborn screening community that we could go talk to find out what are the lab's needs. Do we, yes, we could have a treatment, we could put forward this nomination to the RUSP, but I've been in a situation having worked for the federal government where you get unfunded mandates to move forward. So before we would push for anything with regard to adding it to the RUSP, we wanted to know exactly, labs, what are your concerns with moving forward with a condition like this? What would you need to move forward? What are the testing modalities you use in your lab? So we did a lot of talking to the stakeholders, and after each discussion, it led to another group that we needed to talk to, and then another group. And so I didn't realize at the time I was building a coalition, but that's exactly what we were doing. And we were saying to the folks that we felt that SMA was going to be the next condition added. What can we do to facilitate in your community should this happen? What are your needs? And after we collected all that data, we went back and we worked with our patient advocacy organizations and relayed all of that information to them. Because one of the things that I recognize for the groups, particularly the patient advocacy organizations that may be putting forward these nominations, they don't have the resources. They don't have the time to do what Biogen did. And I think it was helpful to be able to gather that information and sort of hand it off. Here's what we've learned, and here's how you can utilize it in putting that nomination package together. I mean, having SMA on the RUSP was beneficial to Biogen, but it was more beneficial to the SMA community, and the voice of the community needed to speak, not Biogen. But I felt very blessed and fortunate to be able to be a sort of a researcher for that community, to bring them back the tools and the information that they would need to put a submission package together. You really do need to listen. You need to provide funding. We've already talked about the need for pilots. So one of the things I think that industry can do is to provide the resources to support those pilots that are needed to support the RUSP nomination. You need to be able to show that the lab can conduct a test. It can be done cheaply, as Don said in his presentation. And one of the things we did was to work to get a multiplex test that could be multiplexed with another test that was already being done. And to think that you could get a test done, the actual testing process, not going through the whole thing, for under $1, that was really unheard of for the laboratory community. But we wanted to just make sure that all of those ducks that needed to be in a row, and we talked about all of them in the previous presentations, we, in industry, who have the resources and the time, should support the patient advocacy organizations and the laboratory as they have to build up to adding these conditions to their armor. And then the other part, we need to be supportive of publications. If we're finding out new information, because that's that document base that is needed to support the RUSP nomination. I was ever so grateful to see one of our scientists at the time and the CDC folks and folks in some of the newborn screening labs do a publication around testing for spinal muscular atrophy and the test that they multiplexed with SCID, so that information was out there to serve the community as they move forward with the RUSP. I think somebody in my team said back at the time we were doing this, knowledge is power. And the power is not for the industry, the power is for the community. So you collect the knowledge, hand it off so that the community has the power and the resources to move forward with the nomination. But listening and engaging is so important. There were so many meetings that I went to with folks within my company, and they said, well, I didn't realize a newborn screening lab had to do all of that. And actually, I put together a little infographic for them because they kept getting confused. Well, they have a test. I don't understand what the problem is. And I laid out all of the steps for the newborn screening process in a lab. And I said, the test is just the first. I said, the treatment is important, but there are a whole lot of steps. And just understanding what the stakeholders have to engage in is so important. But the first step is listening, to hear their concerns and what their needs are, moving forward with your particular disease state that's going to be added, because each one is different. When I looked at some of the previous RUSP nominations, I tried to glean from them the important nuggets that I should relay to Cure SMA as they were going for it. And I think we had either weekly or bi-monthly calls just for me to, and sometimes I felt like, oh, I talk too much on these calls, but I had gathered so much information that it's just like, and I hope I didn't overwhelm them, but I think in the end things worked out. But you have to find out who your stakeholders are. You have to listen to them, and then you have to figure out ways to address the needs that you know they're going to have along the way with regard to the submission. And I think my role was just being supportive, just supporting the effort. And Annie, I think, Annie, we met earlier at the beginning of our process, and I think talking through with other organizations that were trying to, because we were trying to partner as we went through this, and because it was a different testing modality that would be needed for spinal muscular atrophy versus Duchenne, you know, we had to separate. But I also think, and this has happened to me subsequent to SMA, what you learn, you have to be willing to teach somebody else. You have to be willing to pass on that information. This is a community that thrives on passing it on. You can't do this process and then stop. Oh, I've got mine through. You've got to pass it on.
I completely agree with that. I think that's a really critical piece, is that this information needs to be shared. And I also really appreciate you saying that you didn't realize you were building a coalition. You were you know, and I think that happens with a lot of us and a lot of people. You think you're just going and maybe we'll have one phone call and then that leads to another phone call. And then all of a sudden it's, you know, oh, I'm actually having work groups now. We really are invested. And I feel that way too. When I think, oh yeah, I'll talk to one organization. They're thinking about newborn screening. And then, you know, 6 months later, it's like, oh, well, what's happening? Keeping tabs. And I think that's a great thing. That's very generative. It's important not to feel kind of alone and lost in all of this, because it can be overwhelming. So thank you. Thank you for sharing that. Mary, my question for you is, you know, once a condition is added to the RUSP, what is kind of the work in that is left to do when actually adding the conditions to each state and to each of their panels? As we know, and was mentioned earlier, the RUSP, the R in RUSP is recommended, not required. And so it's really important for us to know that that is one step, one important step, but not the only step. So if you could just speak to kind of what that landscape looks like, you know, after the RUSP, what that work looks like, and the work that you did with coalitions around getting to state implementation for SMA.
So as everyone has spoken, it's almost like as you're working on the RUSP, you may not be able to even think about this next step, which is also really important. As I think all the speakers have alluded to, getting to the RUSP is sort of like the Holy Grail, but it's sort of like halfway there, and we can probably talk about that. But so the next step really is, okay, it's recommended. Every state, as has been already stated, does implements it in their own process. So for example, some states, like California, they actually have it as part of their law that any disorder that is on the RUSP, they have to implement it within 2 years. And California successfully did that with SMA. They implemented it at the end of June. We had approval in July of 18, and they did it by June of 2020. There are several states like that. There are other states where the process is working with the state legislature to get a change in the rules. Carolyn can speak more to that, I'm sure, than I can. But there's a huge advocacy piece. And as Carolyn was saying, you have to listen to the states and find out what do they need in talking with the state labs. Because it was a learning process for us at CureSMA to identify what each state needed in order to move forward. Sometimes it's legislative, sometimes it's the state lab and the resources that they need. And those are the pieces. Now our coalition is an industry coalition, whereby industry and CureSMA work together really to do those legislative advocacy. As Carolyn said, we don't have the resources on the advocacy side to do it all. But we certainly contribute, and we partner with our industry partners in order to sort of tap into the ear on the ground, you know, what people are hearing from their states, because every state also has their own advisory committee meetings that go on, talking about what they need to do and when they will add it if it's not legislated. So advocacy is huge, and the advocacy occurs at the state level. It occurs with the state labs. And we also do great grassroots advocacy by bringing in families to testify at committee meetings as needed and as appropriate. The states often need to hear from their community, their statewide community of individuals impacted by the disorder in order to move forward. I can share with you that an impassioned plea by a family helped Florida move up their timeline to get implementation of SMA, newborn screening. So don't underestimate the impact of the family stories and the impact of diseases. Many state labs have never heard of SMA, and what they know is based more on the technical side, the understanding the laboratory piece of it. They may not know the details about the disease or the family stories or the impact of the treatment that is may be available. So Cure SMA has taken on the role of contacting the labs, providing education about SMA, assessing where they're at, what their needs are. We have created materials to share with families about newborn screening, and also with primary care providers who have never seen this rare, SMA is a rare disorder, and generally we're talking about rare disorders. Sorry, just have to gather what I want to say to you. There's so much to share. So there's that advocacy piece. There's also the healthcare providers, those individuals who are going to receive these referrals. And for some states, it's easy. They know who those, in the case of SMA, the neuromuscular care centers are, because those people have also been advocating on behalf of the disorder to get newborn screening implemented. But there are other states that it may not be as clear. So they require support to help identify centers that either can provide the treatments and the treatment options for patients and are willing to learn more about the disorders so that they can better serve their state population. And we serve and we support them in that as well. We have our core coalition, but in a sense, we have an entire SMA community that we work with to promote SMA newborn screening around the country. And it is multi-layered, many stakeholders, families, industry, the labs, the legislators, healthcare providers are all working together to really move this forward. So I'm trying to think about I hope I've answered the question in a way that's helpful for people. But there is much work to do. But for many of us, it's a labor of love. We see how much, for SMA, everyone knows this information, which is that, for these disorders, for those of us who have struggled with the delayed diagnosis, the diagnostic odyssey, the newborn screening is sort of a no-brainer to make the disease different for these populations. So many of us come at newborn screening from that perspective of, we need this, we need it yesterday, and we're just so anxious to make it happen. But it is a process, stepwise. Take your time, learn about it, learn as much as you can from everyone around you to move that forward, and engage people to do it. Who, as Carolyn was saying, she went and did a ton of research, which many of us have done in looking at our disorder and getting newborn screening for that disorder. But there may be people out there who you didn't think would be a good you didn't think of them as a partner, and when you start to talk to them, they actually have much to offer you. So I encourage you to reach out to us. We're happy to help. Thank you.
Mary, can I underscore something that you just said that sort of builds on the idea of coalitions? Because I think one of the things you just said, I just want to make sure that everyone listening, because we have people in so many different stages of the newborn screening ecosystem and development participating today. And it also goes back to something Michelle Purrier said at the beginning, in that, once your condition is added to the RUSP, which I think a lot of people start off thinking that that's the end goal, you then have the process of having to work towards state implementation in every single state. And that's an individualized process. And for some communities, that has taken up to a decade to work through that process, which means that whether or not babies are screened for the condition that has been recommended by the advisory committee and the Secretary of HHS depends on the state in which that baby was born, so that those babies, there will be potentially life-saving therapies sitting on the shelf for which those babies are not identified. So Mary, I love that you mentioned advocacy, and this is another role for coalitions, because you actually cited legislation in California, and that advocacy work has been done by people participating on this call today. That is RUSP alignment legislation that has been led by EveryLife and many of the partners here, the Community Congress and Rare Disease Community, that wants to take the rocks out of the backpacks of the individual organizations that are moving conditions forward, so that there is a pathway forward for state implementation in partnership with the states, so that once a condition has met the evidence review requirements of the advisory committee, that in working with states to identify funding and appropriate timelines for implementation, that pathway already exists. So as you cited, Mary, that legislation has passed in California and in Florida, and we are now working with our community Congress partners and others to identify which states we move into next. But the goal would be optimally that we would have that legislation in all 50 states, so that organizations could focus on adding a condition to the RUSP and then have a pathway for implementation and not have to try and do that 50 times over, because QRSMA has done a phenomenal job, but the bandwidth that is taken for QRSMA to do that is extraordinary. And for many of our organizations, that's untenable to have to do that. But the alternative is unthinkable, to have babies who are not identified. So I just wanted to underscore that that is another perfect example of coalitions, and we invite people to be a part of that effort with us.
And the state I would recommend to be next on your list, and you probably already know this, is so Texas has legislation every other, what do I say? Their legislature meets every other year.
Yes.
And if you know, so the advisory committee actually we've made progress though this year, even though they're not in session. We have made progress this year, and a commitment to have implementation by June of next year. But it's really difficult when a legislature, or it requires legislation, and you don't have access to the legislature for an entire year. And if you don't get all the work done within the year they meet, you have to wait.
So that's a year's worth of babies born who didn't benefit from the approved therapies in SMA.
Yes. And the other thing I would like to add is that newborn screening for any condition is really just the beginning. I mean, we've talked about all these steps, but then when it is implemented around the country, there is also an obligation to track those babies and the impact of newborn screening across the country. And I know that there's multiple ways that occurs in the U.S. and QRSMA is also tracking those infants as best as we can in our community through our own registry, because that's the payback, if you will. Pay it forward is, okay, we're doing newborn screening for SMA. Well, how does that actually alter the disease? And can we be an example for others to move newborn screening forward?
I agree. I mean, especially Annie knows that whole section of long-term follow-up and that data, that's we could have a whole other summit on that and boot camp on that, and probably is needed. But yes, I think that's really important. And I appreciate you speaking to all the different hurdles that there are to implementation at the state level, and that those hurdles and barriers are typically systematic and process-wise, not person-oriented. I think sometimes it can be really easy to say someone doesn't want this on the panel, when the case is, there's so much that goes into getting a condition on the panel so that we are able to collect data and really know what's going on and educate families and providers. And then when you have this process like you were just talking about, where if you don't do it within that year, those 365 days, then you have to stop. And that can be frustrating for everyone involved, including our partners at the state labs. So now we'll enter kind of the session where I'll just throw out questions and everyone kind of chime in. We've talked a lot about the importance of partners and building coalitions, but I'd like to get a little bit more specific and to hear from you all. For someone who is new to this space and is really thinking about delving into newborn screening, particularly the process of nominating a condition, how would you really recommend identifying early coalition partners, and who are those? And someone, I'm sorry, I can't remember exactly who said, I think it may have been Mary, who said, almost, people who you wouldn't think of that would be good partners, but ended up being good partners. If you could just speak a bit more to the specifics of that and what that looks like in these different categories, and really anyone can chime in who wants to for that question.
Well, for me, again, it was researching who had been the presenters and so on at various advisory committee meetings. I looked through those names and the folks who were there. I looked for publications, people who had published things around SMA, and reaching out to them. I looked at the rare disease organizations and reached out to them and said, who are the movers and shakers if we want to begin this effort to move forward with newborn screening for SMA. And again, Mary is right. There were a lot of people that I met along the way that directed me to other people that okay. There are people who I met within the state legislature that had an interest in newborn screening because they may have had a family member or that had passed away to a condition that if diagnosed early, the child could have survived. So I think, and my hat goes off to APHL. I began to engage with folks at APHL. That led to other interactions. So I just think each touch point leads you to another touch point. But my suggestion: start with APHL, start with the rare disease organizations, and go from there, because they will be able to lead you to other folks who are doing things. That led me to May Baker in Wisconsin, who was doing a lot of work around SCID. And I said, oh, so you're doing SCID. We want to see if we can multiplex SCID with SMA. And she's like, yeah, I'm interested in that. And so that led to other folks who were very interested. And then there are just the opportunities that happen because folks hear that you have an interest in the condition. And there were clinicians that reached out to Biogen to say, hey, we'd like to institute a pilot here in our hospital system. Would you be willing to work with us to do that? And so I just don't think you should ignore any opportunity, because that person may not be specifically interested in your disease state, but they may lead you to somebody else who will be interested. That's been my experience.
Great, thank you. Anyone else want to chime in on that question?
I don't know if it's been said, but APHL is the Association of Public Health Laboratories, and they have a monthly meeting with NBSTRN, sharing their pilot data, which has been very helpful to me as a patient advocacy group, just to understand more as a group what those laboratories are needing. And also I was privileged to be allowed to participate and share what we knew about SMA to try to partner more with those labs. So I just wanted to shout out. Thank you, Carolyn.
Great, thank you. A question that has come in from our audience is, wouldn't the stakeholders be the same across the board for all diseases? And I'd love to hear your takes.
The answer is the type, maybe, but not the partner. For example, in SMA, spinal muscular atrophy, now we have been so fortunate. We have 3 FDA-approved treatments. I mean, it blows my mind every time I think about it. But so that's 3 different manufacturers. And those manufacturers are in particular disease lines, if you will, but they won't be involved in every disease. So you have to look for the partners who maybe are developing a treatment or are very interested in the research in that particular area on the industry side. The state labs are the state labs. It's generally the same people who are doing the newborn screening follow-up and are developing and working on the tests. But I would say the industry partners change. Your family constituents are different as well. Go ahead, Don. Looks like you want to talk too.
Yeah, no, I was just going to agree with you. I think the same stakeholder type is going to be needed across every disorder, whether it's a patient advocacy group or industry or laboratory people or the clinicians or the follow-up people. But there may be some overlap across disorders. I'm sure there are, but for the most part, it requires a unique consortium, which is a challenge when you've got hundreds of rare diseases out there, and you got to say, okay, now what's the right coalition for this particular disorder? And I think a lot of these initiatives are started by patient advocacy groups. There are some big ones that have their own, government relations offices and so forth, but there are a lot of very small ones out there. Might be just one or two parents that have started the organization. They're extremely passionate about this. It becomes a major goal for them, but it's a huge lift for an organization like that. And so finding what you were talking about earlier, finding another organization that's already been through it to lean on and to help provide guide, but then as quickly as you can, bringing in, for some groups, it's finding the right clinical researcher, someone who maybe has had a clinic for patients of that type for many years, has seen the consequences of late diagnosis and works hard to treat those children and just has a passion for that particular disorder. And other times it might be someone who's developed a lab test, or it might be a drug company that's developed a treatment. So there are going to be different key advocates for each disorder, unfortunately. But there are lessons learned across all of them that I think can help really enhance the process. And
and one thing just to add to that is because it's the same but different. But because of that, I think also including organizations that work across disease groups can be really important, because they can see how
right.
have trended and what information that may have been really relevant and true a decade ago may have evolved, and there may be things that we are just faster at and can connect to different people much quicker. So I think sometimes that's thought of a little bit later in the game.
So can I add one more stakeholder that we don't often think about, but we should, and I think we haven't mentioned today. We talked about drug manufacturers, but we also need to look to some device manufacturers for the newer technologies to do some of the testing. I know earlier on, before Biogen looked to engage with some diagnostic manufacturers to see their interest in developing some tools that could be used by the lab to perform some of these the testing. I don't want to leave them out, because it didn't we didn't need it directly for SMA, but there may be some other disease conditions that you may want to consider reaching out to some diagnostic companies to bring them into the mix as well, rather than just drug companies that may be able to assist you in the process. And it will also oftentimes help them if it's a product that hasn't yet received FDA approval or something. Some of the validation that they need to do for their instruments and so on, maybe, it may be a symbiotic relationship, but I don't want to leave them out. And that just came to mind.
That's great.
Just one last thing is, I just want to say to people, I just over and over again, don't reinvent the wheel.
Yeah.
So if something's been done really well by somebody else, I just found all of the partners to be so generous in sharing resources and best practices. When we were developing for the Duchenne pilot, the educational materials that we would develop for families, we reached out to so many communities that had already conducted pilots or had programs, and asked them for their materials and resources. And then I'm going to do a plug for Natasha and Expecting Help. And then we worked with their team to help us refine those and update them, and then worked with the genetic counselors at EPMD to tailor them to what we needed in Duchenne. But we didn't start from nothing. We didn't start from ground zero. We started from things that were already IRB approved, that were already being used for newborn screening programs, and then modified them and tailored them to what we needed in Duchenne. And that's just one example of a place we did that. And so sort of a call to others who are in the space to share freely what we have so that we can really make sure that these are an exchange of good and best practices so that we're always getting better and better and that we're always improving these programs for the families that we're serving.
Great, thank you. I think that's very true. And the only thing better than creating something and using it yourself is realizing that it's useful for someone else. And I think especially in this community, you have a bunch of people say, take it, just take it. And if you can even make it better, that's even more wonderful. So that's definitely true and definitely a theme in the newborn screening community. I have a page more of questions that we could go on, but we will be closing it here. Thank you so much to our panelists for sharing all of your perspectives and all of the information that you shared today. We know that there are some questions that are still coming in, but we will definitely connect people to the answers that they need. Again, thank you to the panelists, and I will hand it off to Dylan to close this out.
Great, and thank you so much to everybody on the panel today for such a wonderful discussion on the importance of the coalition building and how it can really impact newborn screening. Just a quick thank you again to our sponsors for making today possible. And a thank you to everybody who attended. This was a great opening session to our newborn screening bootcamp, and we're really excited about the presentations to come. A few housekeeping items. There's questions throughout the day about whether or not where these materials will live. They will live on the Every Life website, but the PowerPoints, there will be a video, they will all be accessible after today's presentation. In addition, as Natasha stated, there are many questions that went unanswered, unfortunately, but we want to make sure that anybody who had a question get a question answered. And so in the follow-up email that will be going out, there will be my email address as well as speaker email addresses. So please feel free to reach out to us so that we can help answer the questions that you need answered. And lastly, we hope to see you next week. We're really excited about next week. We're going to focus more on kind of the data side of it. So we're going to talk about the importance of longitudinal data, the evidence review process, and really dive deep into pilot studies in terms of what is needed to launch them and really how to help run them. So thank you again to all of our speakers and for all of our attendees for being here today. And we look forward to seeing you guys again next week. Thank you.
Bye.
Bye, thank you.
Thank you.
Yes.
Thank you.